right, good morning, everyone. This is a Great Lakes ROTA-RC presentation on the recovery-oriented systems of care. It's part of our Know Your Resources series that will be running through the end of February right now, although you never know. We might be adding more to that series, so just keep on watching. Today's session is hosted by our partner, UW-Madison Division of Extension, so I just want to take a minute to thank them for hosting or sponsoring our session today. I'll be your host today. My name is Amanda Cura. I'm the Regional Project Manager for the Great Lakes ROTA-RC. Before we get started into our presentation, I'd have a few housekeeping sessions or items that we need to go through. So I'm going to ask Kris to just advance our slide here, and I'll go through some of those. The first is to just mention our funding acknowledgement to talk about who we are and where we come from and what we're about. And that's just to acknowledge that we are a SAMHSA, which is a Substance Abuse and Mental Health Services Administration project. And as part of that project, we promote and provide training and technical assistance to the Health and Human Services Region 5, which is those lovely states that you see on your screen right there. If you're not familiar with that region, it is Illinois, Indiana, Michigan, Minnesota, Ohio, and Wisconsin. So welcome in friends from those states. And welcome in those of you who are visiting from outside those states. We're always happy to have everyone. Again, as part of that process of what we do in our project, it's to provide virtual and/or on-demand education, evidence-based resources and research, as well as technical outreach to professionals working in and with rural communities. Although we do say professionals, we want to make sure that we include that is students, it is volunteers, it is anyone working in and around the field of substance abuse and mental health services. We're going to move now and talk a little bit about our website. You see the link that's there on the screen, but we want to also provide you with just a quick shot or view of what our website looks like. So Kris, go ahead and advance one slide there. This is our resource library. We want to encourage you to take a look at our website. It is getting bolder, brasser, more beautiful. Please check it out. This resource library is a wealth of information. It guides you to some of our partners, the TTCs, the ORNs, SAMHSA. It also grounds you to a lot of the resources throughout our states partnerships. So if you want to learn more about what's available in the Great Lakes, down to local programs, state funded partnerships, please check it out. Check out all of the menu items. Check out the front page for the latest and greatest. If you want to know more about training, just go visit. It's all there. The last thing I want to talk about as we prepare for today's session is just kind of ground ourselves into the space and get ready for our training. So let's just take a moment to promote the use of affirming person first language when discussing behavioral health disorders. As we create that environment of learning together, we want to just take a minute to feel welcoming and safe for everyone here, for ourselves. Let's work together to manage a space that supports non-stigmatizing, recovery-oriented language that can help reduce that negative bias and promote engagement. As always, we invite everyone to learn about successful prevention, treatment, and recovery from whatever space you are joining us from today. And we welcome you formally into the Great Lakes ROTA-RC community of learning. I want to welcome now our presenter for today. Kris Kelly is a project manager for the Peer Recovery Center of Excellence at the University of Wisconsin-Madison. She's also a subject matter expert on peer recovery support services, and Kris has developed best practice for integrating recovery supports into a wide variety of systems and services. As a former ED and Director of Programs for Recovery Community Organization, Kris is a leader in the peer support movement in Minnesota. Kris has presented at state and national conferences on topics ranging from supervision and peer recovery support services, integrating peer support services into behavioral health organizations, and recovery-oriented systems of care. I'm going to stop now, and I'm going to hand all of us over to Kris's capable hands.
Thanks, Amanda. I appreciate it. Welcome, everybody. As Amanda said, my name is Kris Kelly. I'm a person in long-term recovery. That's really what brought me into this entire field of recovery was uh, the motivation to make things different for those who come after me. And so, not to say that I had horrible experiences, but I definitely knew things could be different. They could be better. They could be smoother. And so I come to this work through that lens, not through a clinical lens. I did run a recovery community organization, and that's really where I learned a lot about peer recovery support services and just recovery support services in general. And I see their value, their worth, their necessity in helping people not only access but sustain their chosen pathway. I will preface today's talk in saying that I come to this work through the substance use disorder field. And certainly recovery-oriented systems of care cover prevention, mental health, substance use disorders, a wide variety of supports. And when I'm talking today, I definitely have a lens of substance use disorders. And so I just want to say for any mental health practitioners, I'm not ignoring you, but I'm going to speak from my own expertise, and certainly don't want to feel anyone to feel like I'm discluding them from the conversation. Amanda covered this a little bit, but we always start with language matters. You see here we have the ATTC network emblem there. And so I do work for the Great Lakes ATTC, which is a Addiction Technology Transfer Center. And I also work at the Peer Recovery Center of Excellence. And so both these are training and technical assistance centers funded through SAMHSA that provide resources, support, evidence-based practices, much like the ROTAs, to our behavioral health practitioners communities. So where I like to start off conversations about recovery-oriented systems of care is asking ourselves the question of, what if our system of care for both substance use disorders and mental health challenges were not guided by a payment methodology, but on the lessons drawn from millions of people who've achieved long-term recovery? So again, just not to answer now, but to maybe just kind of unleash that power in your brain of what if we didn't have to follow the silos and systems that our services were built within, but what if we had a fresh, clean map to draw, like what should this look like? What's best for that individual navigating the system, that individual who needs some support and help, overcoming a substance use challenge or a mental health challenge. And so that's where we kind of tune into recovery-oriented systems of care. I would call I almost think of recovery-oriented systems of care as a movement, much like other social justice movement, maybe the HIV/AIDS movement. Certainly, we have a lot of in common with disability rights movements. And so the idea is that people who are impacted, people who've maybe achieved recovery, maybe people who haven't achieved recovery and still struggle, that they're advocates within our systems. And so it's these grassroots efforts, kind of bottom up, saying to the larger system of care, the way we have things set up isn't necessarily working. That things feel very disjointed, and oftentimes, like I said earlier, that comes from disjointed funding streams. And so where somebody might enter a system at point A and then bounce to point B to point C, and there's not really continuity. And us as practitioners know that often anytime we're bumping from one point to another, there's always a kind of sad opportunity for somebody to fall through the cracks, for not to have trouble navigating that space. And so the concept of recovery-oriented systems of care was born. I have a couple different definitions here. SAMHSA has its own definition as well. but really it's about how can we support people in gaining a meaningful life in a community of their choosing with the supports they need to become a full citizen, an active, engaged, full citizen in the community. I'm just going to pause for a moment and say feel free to type questions into the chat as I go. We don't have to save them for the end. Amanda's going to also help me keep my eye on the chat because sometimes when I get really excited about this topic, I might not be looking at the chat. So if you want me to pause or you have a clarifying question, definitely just feel free to put that into the chat. And between Amanda and I, we might just pause and return to your question. So let's think about the question, why are we even talking about recovery-oriented systems of care? So what we know is I have the blue arrow pointing to the area where we do pretty well as a community, as a whole, as a healthcare system. We have lots of different versions of recovery, initiation, and stabilization. So that's often what we call treatment, right? So that's where it might be intensive, it might be outpatient services, it might be one-to-one therapy. It can look like a lot of different things, but where, a lot of our funding and focus is on that recovery, initiation, and stabilization. That leaves us kind of other areas to explore yet. So pre-recovery, certainly, like how do we help people intervene earlier, recognize symptoms earlier so that maybe people don't need that full, those super intensive services. How do we help people maintain efforts gained through some sort of kind of treatment process? How do we help people? Sorry, I'm just going to mute that. How do we help people, just like if we have high blood pressure, we're going into the doctor frequently, we're having that cuff put on, somebody's measuring our blood pressure, they're saying, yep, these medications are working well, this is really stable. How do we kind of have that same outlook on our mental health challenges and substance use disorder challenges? Sorry, I'm just pausing. Somebody has their mute button keeps coming off, so I'll just a reminder just to keep your line muted if possible. So anyway, so how do we look at recovery maintenance and offer these same types of supports as we see often with physical health conditions? So again, I was talking about blood pressure, but like diabetes, people do a blood glucose check. So how do we build in these types of kind of check-ins around mental health and substance use disorders? Something I know from personal experience is that when I left my final treatment, there was no outreach. I never spoke to anyone ever again in 15 years about how my recovery is going. And it kind of blew my mind, to be honest, that I had a severe kind of deadly disease or a diagnosis. It depends kind of how you look at substance use disorders, and that I could leave a 30-day stay in treatment and that there was no follow-up, that nothing happens afterwards. There are things available. Normally those might come in the form of social support groups, mutual aid recovery support groups, community centers, but those are things that I would have to seek out. And so meaning I'd have to have a pretty stable life. I'd have to have a home, employment, a purpose in life in order to access those things. So we need to do more work in that area. And certainly we want people to have the optimal quality of life, both personal and in their family, when they're kind of when they're able to grow their recovery capital to a point that they can do that, have meaningful employment and feel like they belong in the community and feel like they're a full, active, engaged citizen where they live. And then certainly the idea of breaking those intergenerational cycles. And I kind of like to flip it on its head and say, how do we build intergenerational cycles of recovery so that it kind of spreads not only to our family, but in our neighborhood and our larger communities? Any questions yet, Amanda?
So just a comment from one participant recently learned that in their community mental health center is set up to serve only those on Medicaid involved with DCS or the criminal justice system. Such a shame that there's no help to prevent the fire, but you can only get help after you're on fire. From what they can tell, this developed because of the funding streams of various systems.
Yes, Tanya, you're speaking my language. And so, and this kind of goes to, I really follow a lot of the work of Dr. John Kelly at the Recovery Research Institute at Harvard. He tackles a lot of topics around recovery support services, recovery-oriented systems of care. Um, I'll be sure that we get the link. I don't think I added it to my resources, but if you just even Google Recovery Research Institute, he has a wealth of topics out there and different studies that he's done. And so one of the studies I like to reference is he did some research on a group of 2,000 people, and people had anywhere from 1 week to 40 years in recovery. A lot of this is because it's kind of a mystery. Like, why do people recover? We kind of haven't figured out that formula. I don't know that it's one formula, but definitely more research is needed in that area. But so he did a research study on a group of 2,000. And what he found out over this long-term study was that once people can get to about 5 years in recovery, and again, it's how they define recovery, the individual defines recovery, they become no more likely to be diagnosed with a substance use disorder than that of the general population. And so if we think about how our services are designed, we often kind of have these short-term acute care stays, like 30, 60, 90 days. And then we don't have a formulated system for what happens after that. Again, resources and support might exist within our community, but there's not much continuity between those. And often people are left to seek those out on their own. And then so I say that to say, think if we had a system that offered this continuity of care to get people to these milestones or markers where we know that the risk of a return of their diagnosis is to that point of the general population. And out of the same study, an interesting piece of information is, although we see a huge growth in recovery capital and a decline in psychological distress in those first 5 years, it takes about 15 years for someone who had a substance use disorder diagnosis to have the same quality of life as the general population. And so I point this out because although we may not be at risk for a return to use at 5 years, or our risk may be comparable to that of the general population, it still takes an additional 10 years to have the same quality of life as the general population. I think we need to shorten that time. I don't think it should take 15 years for someone to have the same quality of life as their other community members, neighbors, friends, family, and all that. And so John Kelly also really uses a burning building model. And so he says in our current in our current systems of care, again, we've gotten good at putting the fire out, so that kind of stabilization phase. And we really need to be looking at what are the building materials people need. So we look towards housing, employment, education, that purpose, a community where they feel like they belong. And then we certainly need to look at building permits. And so right now, a lot of people might have interactions with the justice system. They might have certain offenses on their record, and those things are barriers to, you can't access a FAFSA and student loans if you have a felony offense. It's hard to get employment. It's hard to find a place to live, to get loans, or to be somebody who can rent an apartment. And so those are the building permits we're looking at, is like, how do we help people take down some of those barriers so that they can have a normal life in the community. And so if we look at social determinants of behavioral health, we know we're talking about things that impact oftentimes people who've experienced mental health and substance use challenges. So poverty, unstable housing, involuntary unemployment. And something we know is that it's extremely difficult to recover if you don't have a home, if you're not connected to family or friends, or don't have a sense of community, and certainly if you don't have an income. And so this all comes back to that idea of like, why recovery-oriented systems of care? We're doing a fairly good job on that stabilization part, but we really need to create a whole system to wrap around individuals, invite them into a community where the resources exist, where they live, work, and play. And then have providers, whether that's peer recovery support services or just allies, family members, come alongside them and intentionally help them navigate those spaces. So some elements of a recovery-oriented system of care. We look at public education and prevention. So again, we don't want to wait till the fire starts. And Tanya was, I think, kind of referencing that, like, how can we do more upfront so that people don't necessarily have to experience any negative consequences that might come alongside substance use challenges or mental health challenges. Continuity of contact over a sustained period of time. So what would it look like if when somebody, came into a system, that they had 3 to 5 years of consistent support really mapped out? What if we thought about it that way within our systems of care? And we started to kind of build that long-term recovery management. We know that when family or friends are involved in someone's care and into their healing pathway, we know that supports that person in healing. I feel like we're still kind of coming out of a space of sometimes family members are actually intentionally discluded from people's healing processes and getting well in overcoming substance use and mental health challenges. And what we know is if we can get in there, engage and educate the family or friends, whoever their social support system is, we know if we can engage them, that increases the opportunity for someone to sustain their recovery. Access to the latest advances in medication-assisted treatments. It still kind of boggles my mind sometimes that we have really concrete evidence that medications work, and we know that medications work for substance use disorders, and yet our system, some places in our system, we still have some resistance to offering the full array of medications available. I come from the peer recovery support world, and so I know the power of that. I always like to mention that peer recovery support services go beyond direct services. And so when we think about it, really peer recovery support providers, part of their role is to advocate for what's in the best interest of the person they're working with. So advocate, be a voice, amplify that person's voice in team meetings and in different settings. And then also to advocate with the larger system so that we can see some of these changes that I'm talking about, so that we can increase continuity in care, that people really, that we see a full continuum of care that has different supports all along the way. And so that's part of a role of a peer recovery specialist, both in mental health and substance use disorder services, is to advocate for that, that larger transformational systems change. And then we've already touched on the sustained monitoring or recovery management. A lot of times it has different names. And I think we have a lot of work to do with early reintervention. Again, once people come through a system and maybe they've achieved 4 or 5 years of recovery, right now our system is often set up that they have to experience pretty severe negative consequences in order to be re-engaged in services. And so we see people kind of really dip down, and maybe they're losing touch with their friends and family, losing employment, potentially losing where they live. They have all these very, very significant life-altering changes before the system of support can come in, and they can utilize insurance or the healthcare system in order to re-engage in services and actually get re-diagnosed. So what can we do to help people for earlier re-intervention? So when they say something feels amiss, we believe them and we welcome them into services and say, let's not have all those losses. We can help you right now. This is a diagram that I took from a report from Hancock County, Ohio, it's from a different, I have the link in the references at the end, but it's a kind of a seminal paper written about recovery-oriented systems of care, and gives you the history and then a snapshot of where we are now. I thought this diagram it did a really good job of lining up the stages of recovery and then ongoing recovery supports needed. So within if we're thinking about developing a recovery-oriented system of care, whether that's at a county level, a state level, a national level, we have to think about integrated mental health and substance use authority, whatever that may be. We can certainly advocate for recovery-oriented systems of care from the bottom up, but eventually we do need support of the broader system, decision makers, funders, those type of people, because it's systems transformation work. And that integrated authority needs to be connected to state agencies and partners. It goes beyond just behavioral health into public health and our justice system, other community supports, and then community collaboration. So we always want to ensure too, we have the people impacted at the table, whether that's individuals in recovery, their friends and family, professionals who serve them. We want to have those folks a part of this process too. And so the model is based on, we do public education and prevention work alongside assertive outreach and engagement. We know that stigma prevents a lot of people from even asking for help. So we can't just have brick and mortar spaces where people have to enter into in order to get support. We need to be out in our communities. We need to be able to have conversations and kind of normalize substance use and mental health challenges, so that people feel comfortable and understand they're not alone, that hopefully they won't be shamed if they do get a diagnosis, and that there is help, support, and hope out there for them. And then certainly that kind of acute care stabilization rehabilitation piece, and then the monitoring and early re-intervention. And so we're helping people, again, regain full citizenship as members of our communities. I'm just going to pause here and ask maybe for some raise hands or thumbs up if everything I'm saying so far is making sense or if I'm moving too fast. I get excited about this topic and I love this topic, and I never know if I'm speaking to, okay, lots of thumbs up. Any questions right now? And feel free to come off mute and ask or type in the chat. Everything seems to be making sense. Okay, so I'm just going to keep going. So we've kind of covered this continuity of care and supporting people throughout their continuum of wellness. I've touched on it a couple times, so I just want to make sure everybody knows there's a thing called recovery capital, and it's a way we, in the recovery community, measure people's, I guess you could say, progress on their recovery pathway. So oftentimes assessment or some type of intake is done, and then it gives the recovery community a way, or peer recovery support specialists, a way to measure growth in people's recovery capital. And so recovery capital really takes kind of social, physical, cultural, and then human recovery capital. So kind of these four broad areas, and looks at, not only is abstinence or removal of symptoms. We want to press up against that. Abstinence or a removal of symptoms means recovery, right? We want to look at these buckets of social, physical, cultural, and human. Do people have transportation? Do they have housing? Do they have employment? Do they have skills and abilities? Are they growing their knowledge base? Do they feel like they belong to a cultural community of their choosing? And then do they have people in their life that support their recovery? So recovery capital is the assets that people bring to the table. So it's very strengths-based and person-centered. And we're starting to look at different ways we can measure recovery capital. So we can measure that individual recovery capital. We can measure family recovery capital. And then now we're looking at, can we measure community recovery capital? So we can find, locate, recognize the resources a community brings to improve, health and wellness for everyone in the recovery community. So what are those building blocks? What do we need to be doing? And this includes, building strong prevention programs, building supports and outreach programs, not only to individuals, but to family members. We know family members are often first responders. They're often the ones who say something's not right, something's amiss, something's going wrong. And we want to be really responsive to those family members, because again, how wonderful if we can move things upstream so people don't have to face these really severe negative consequences or outcomes of their substance use or mental health challenges. We want to make sure like our full community is brought in, not just behavioral health, but are we talking to churches and faith-based organizations, our jail system, our court system, our local businesses. A recovery-oriented system of care is outside the behavioral health care system. So how do we start to make some of those connections and bring more people to the table? I'm sure many people have heard of the philosophy of the healing forest, and I like to always kind of come back to this idea of the healing forest is really a concept where if you're in a forest and there's a tree that's just not doing well and it's losing all its leaves too early and just really struggling to grow, and you pluck up that tree and you bring it over and you put it in the perfect spot in the healthiest soil, you water it every day, it gets plenty of sun, and you see that tree's life really turn around and it's blossoming and it's just beautiful and strong. And if we take that same tree and pluck it up and return it to the forest, if the soil's sick and it gets no sun and it doesn't get any water or proper amounts of water, we know that that tree won't thrive any longer. And so we use the concept of a healing forest, just like what we do with the people we serve often is we pluck them up out of their environment and we take them over here and we get them really well, because it's a controlled environment and they're having access to healthy foods and exercise and other people having similar experiences. And then we return them back home. And sometimes home isn't safe. Sometimes home isn't healthy. And so if we want to kind of sustain gains made by the stabilization services or treatment services, as providers, we also have to look at that soil, that forest. Where's somebody going back to? And then find ways to work on that and create that healthy, thriving forest so that people can maintain some gains made. I see maybe a question.
Yes, so Brooke is interested in community recovery capital. Are there some resources that you could point us to?
Yeah, what I'll do, Brooke, is there's a couple existing references I already have on my last slide, so you'll get those when I share. And it's really I'll say a newer concept of measuring community recovery capital. So Dr. David Best is doing some work on that, and so it's tricky because how do we know what things are just regular community things and what things do we know are specific to recovery? And I'm not a researcher, so forgive me for kind of muttering my way through that. But yes, I can give you some resources around community recovery capital, because that really leads us to kind of talking about this recovery capital, community recovery capital as a way to getting towards conversations around population health, right? We all do better when we all do better. We know if we have people who are supported in their recovery, they're tax-paying citizens, they vote, they're members of our neighborhood programs. I mean, entire communities are kind of uplifted when we support people. So I just wanted to touch on some aspects of community asset building. And so part of this is how can we do this, whether we work in prevention, treatment, recovery, harm reduction, in our work, how can we also look at the building assets within our communities, because that's an important part of the continuum of care. So these are just some ideas or bullets of what is a part of community asset building. So increasing confidence and self-belief. Yeah, you can read this. So if we think about approaches to implementing a recovery-oriented system of care, if you went state by state and really looked at every state is going to do it a little bit differently. One thing I've seen places that have had some success, or states that have had some success in implementing a recovery oriented system of care, is that both bottom down or bottom up, top down approach, that both decision makers, policy makers, people who are working within a department of behavioral health, sometimes public health, so decision makers and funding are accessible, and then that the community is brought in, not just to implement, but actually in the design and developments, so that they're brought in, when this concept is being talked about. We know it's important to kind of have 3 different approaches. So we want to have conceptual alignment, practice alignment, and contextual alignment. It's not to say you can't create a recovery-oriented system of care, with all of these, without one of these present. But when you have all 3, it really institutionalizes the practice so it outlives an advocate. And I'll talk later on specifically about the Great Lakes region and what different states are doing. But I've seen states kind of one person at the Department of Human Services was the advocate, was the champion. And then when they left their position, those efforts died out. So we have to think about like, have that one advocate really find other partners, and we start to do a ton of education, and then that we're funding coalitions or different groups to really carry this work forward and to ensure stability, because it's really easy for ROSC efforts to kind of die off if we don't have these three components. And so really looking at too the contextual alignment. So ROSC isn't just about direct services, but it often includes policy changes, fiscal and regulatory changes, and then creating those administrative infrastructures that may exist out in the community. They may also exist within the behavioral health division. Like in Georgia, they have a Office of Recovery Transformation, and that sits alongside their Department of Human Services. And so they institutionalize their efforts, and they gave it a name, and there's employees working there, and they're ensuring that this work moves forward. And kind of part two of that, part of systems transformation, is we often look at additive, selective, or transformational approaches. I would say from what I see, we're well versed in additive. We're well versed all around in the behavioral healthcare system of saying, here's the set of services, and we're going to add on a couple additional services to make this a little more recovery conducive. So that might be like adding a peer to a team, to an existing treatment team, and not really change much else. Selective is when we go in and we look at which part of the system are we going to transform. And then a transformational approach is deep. It takes time. This is where we're looking at that decade. We're looking at starting today, in a decade, where will we be? But it also brings in cultural components, this value-based change. Again, community members are at the table. It's deep. We're changing laws and statutes. We're kind of reviewing, like, are there barriers in those areas? What can we do about it? I know in Minnesota, part of our substance use disorder reform is an 1115 waiver with Medicaid. And so again, these are big, long-term, deep changes. And that's where we really get like that kind of a polar shift in how we see people able to access our systems, participate in our systems of care, and then certainly, part with those systems of care in a way that they're not cut off from services, but that they can maintain some sort of services. I'm going to pause again for questions, because I was just going to dive into different statewide ROSC efforts in the Great Lakes region. Is there anything I've said that you want to know more about? And some of my resources will let you take much deeper dives into the how different states have done this, how different counties have done this. And I'll tell you a little bit about my experiences. There's no questions right now. I'll jump into some different efforts in our region. So I was fortunate enough working through the Great Lakes ATTC to join Illinois' ROSC efforts. So we came in as coaches and partners with the Substance Use Prevention and Recovery Division, so SUPER we call it, to look at how can we start that transformational approach in Illinois. And what they wanted to do was support the development of state coalitions statewide. And so the first approach in 2018 was to release some funding to support the development of different recovery community organizations and recovery community centers. Um, what they did was they really opened up who traditionally accesses these types of grants and promoted them to prevention communities. So a lot of prevention communities applied for funding to start these ROSC councils and do some sort of kind of recovery community center work. It looked different across the state, what people ended up doing. But I think we started with 5 ROSC councils in 2018. And each of those individual councils created a table in their community that had what, like I said earlier, not only behavioral health care providers, but local law enforcement, judges, child care providers, local education institutions, food pantries. It was a wide variety of people at the table to talk about what are the barriers and what could be better. Where can we make connections and maintain those connections? And a lot of times a program or a new idea, a new way of thinking would bubble up through those connections. And so we started off, like I said, we kind of did one in these 5 different regions of Illinois. Through the Great Lakes, our role was to provide individual coaches. So I was a coach for 3 coalitions and would help them formulate a work plan. What is year 1, year 2, year 3 going to look like? And then coached them through different ideas that they could try to implement. And each coalition had the freedom to make a work plan that worked for them, because what was going to work in Chicago, Illinois looked very different than what was going to work in Bloomington, Illinois. So when we go out to a rural community, we can't expect urban, suburban, and rural communities to come up with the same exact set of items, things to work on. We let them develop them, and then they had funding to actually implement those ideas. And I just was looking last night, and from what I could see from 2018, within those 5 regions, they now have 61 of those councils and coalitions doing this work. And so that was a lot of growth from 5 in a really short amount of time. In 2023, so just this last year, we wrapped up the Great Lakes work with them in that coaching, because they were able to fund it internally. And again, now they institutionalize these efforts with some support from a technical assistance provider, so that now they have a continuous funding stream to support these ROSC councils and coalitions, and support this community-based work of growing that community recovery capital. It's a super exciting project. Again, I have a link to their website where you can kind of read a little bit more about it. So I would consider that a successful effort. We know in Michigan, again, someone in the Behavioral Health Care Administration said, we want to change things. We're ready to take this transformational approach. So in 2010, they actually set up a coalition that included state members from across the state. And so they called it their Transformation Steering Committee. And they really guided a process to come up with this framework. So it probably looks similar to what I showed you a couple slides ago, but aligning concepts. So in other words, changing the way we think, aligning practices. So how can we use language and practices at all levels to implement these value-based changes? And then aligning context. So how can those behavioral health divisions or health departments kind of change that regulatory environment or policies that might not be conducive to a recovery-oriented system of care? So listening to community members about their experiences, about, again, what was successful and maybe what was more challenging, and then taking that information to actually make those institutional changes, the policy changes, so that we start to kind of see that ball starts rolling towards easier access, which means hopefully we can intervene or help people earlier if they're experiencing a substance use or mental health challenge. And again, I left a link in the end so you can read more about Michigan's approach, so that they have 14 years of experience doing this. Within Ohio, I worked with Patricia Stubbe is her name, and so she was in Hancock County, and she really led the efforts in Hancock County to do a more county-wide, develop a county-wide recovery-oriented system of care. Mike Flaherty is a leader in kind of recovery-oriented system of care work, and so I pulled out this quote from him, or this paragraph from him, because it really kind of hit me. So I'm just going to read this out loud. So, given today's need for improved population health, transforming any system of care is daunting, urgent, and necessary, but it is doable. Access and retention in behavioral health and primary health, provided by competent workers and healthy programs that service and represent the community values and needs, are where local policy meets science and healing can begin. Hancock County took such a challenge, begun by educating and empowering its citizens and its providers to define and seek their own sought health outcomes. They built the system community interrelationship necessary to achieve that vision. So I just think that's so cool to think about. We're not just saying change the current system, but we're saying that question I asked you in the very beginning. What if our care wasn't determined by funding streams? What if we sat down and we imagined a system of what it would look like to care for our citizens who struggle with mental health and substance use? And we drafted out, we blueprinted that system, and then we look to our funding streams to say what can work where. And I won't kid you, like I said before, these are approaches that can take a decade, but I myself am kind of willing to work towards that future. Out of a fairly extensive document, the resources in the references at the end, I pulled out these 3 items of something Hancock County looked at, that they came up with as a few of their initial overarching core measures to determine, hey, are these efforts working? So access, what they saw is a 284% increase in individuals served in the behavioral health system in Hancock County from 2014 to 2020. So I would say that's a success. So one of their areas they wanted was, how can we welcome more people into our care, kind of widen that doorway. So I'd say they had some success there through their efforts. Retention, so like, how do we keep people engaged once they're here? And this isn't coercive. It's more of they really reflected on even terminology we use, or kind of how we do business. We know it's can be common practice that people are asked or told they need to leave a treatment setting when they show symptoms of their diagnosis. Kind of mind-blowing when you think about it. And so they actually looked at, like, how can we change practice that might be business as usual, and it's going to be uncomfortable for our providers. But they really looked at that and made some significant changes. So they knew, they moved to 51% of all people served achieve 90 days of sustained within their continuum of care with recovery support services. And that's a pretty good start for folks. And then they really wanted to look at outcomes. So again, how do we start to measure outcomes to date, at least in the substance use disorder field. We measure outcomes based on when that person is active in services. We do our best to measure beyond that, but we don't have a ton of information on long-term outcomes from a specific treatment intervention. And so how do we start to look at and measure and have some data so we can do some data-driven decision making when we're at these tables, building these coalitions and asking policymakers to make pretty robust changes. Let's try to have some data to go along with that. I really highly suggest you read the paper, the PDF on Hancock County, because it really walks you through where they started, gains they've made, who was at the table, how they did it there. It's a super exciting piece of information. And then looking at other ROSC efforts, so Minnesota, I would say in the it was around like 2014, the state of Minnesota, the Behavioral Health Division invited in some ROSC consultants. So we worked with Ajama Achara, who owns Achara Consulting, and she's a national expert on recovery-oriented systems of care, and she did a lot of work with the city of Philadelphia in creating their recovery-oriented system of care efforts. So she came to Minnesota in 2014. We had some really strong advocates within the behavioral health division at that level, and she kind of helped us draft that blueprint. And unfortunately, some of those advocates left the department, and then we lost a lot of kind of emphasis on these efforts. And so that's why I mentioned that earlier, that as soon as we have an advocate, we need to grow those champions, because we don't want one person to carry that on their shoulders. And if something happens to them or they leave, sometimes those efforts die. But the recovery community has kept it moving. And so I think we've seen now our behavioral health division kind of come full circle and work on some major substance use disorder reforms, and they've been inviting the community to the table. And then our governor actually opened an office of addiction and recovery. So that was a way to further ensure that our behavioral health division has the support and knowledge it needs. The Office of Addiction and Recovery's council includes people with lived experience and then a variety of other professionals. And then if we look at Indiana is doing amazing things. So they developed recovery engagement centers across the state, and they worked with the National Council for Mental Wellbeing on creating a trauma-informed, recovery-oriented system of care toolkit. Again, the toolkit's in the references. It's free to access and take a look at. Indiana also really took some leaders in the recovery community and looked at that. How can we intervene sooner? What's an innovation and outreach that we could do? And so they worked with I think it was kind of the CHIP SNAP system. So where people apply for food benefits, or if they need, support with their children. And as people filled out their application, they were flagged, not in a bad way, but in a good way, if maybe they needed some outreach. Maybe if somebody, a peer or somebody from a recovery engagement center, could come alongside them and not wait for them to come in, but reach out and say, how are things going? What are the barriers right now? What can we do to be helpful? And that was an amazing project. And again, a way that they figured out how to institutionalize their ROSC efforts so that it just becomes a part of the regular system, and that we can offer referrals and engage people in care sooner than if we just are more passive. I know a lot about Wisconsin's kind of peer recovery support system. I don't know so much about ROSC efforts. But I know they have a group, Wisconsin Connect, so a group of different providers that come together and same, they're looking at what are the challenges, how can we grow more resources and support within the system and within communities. And then this I take from, if we're building a ROSC, it's kind of simple but not easy. We support what helps. When I was training peer recovery specialists in my last job, at the sometime during the training, we would ask a group of anywhere, 30 people. And this is hundreds and hundreds and hundreds of people over time. What helped you recover? When we asked that, these are the buckets that showed up. When we said what was really important, what was vital, what made your recovery possible, these are the things that showed up on that paper for hundreds of people: family, support, friends, forgiveness, compassion, resiliency, helping others, giving back, feeling like I have a purpose, education, new beginnings, taking action. And so we know as a system what helps. We know that we've done some good work in our communities, creating places for that stabilization and that kind of shorter term care. And now how do we expand that continuum so that people have care earlier and that they have care once they leave those stabilizing services. I think that's it, Amanda. Any
That's not it.
questions?
That's a lot. Um, We've got a comment by Julie just acknowledging that the SUD field has changed and improved over the years due to programs like this and the National Association of Addictions Professionals and local groups.
Absolutely. Absolutely.
And then Eric is asking, can you post the website so we can click it in the chat, please?
The Recovery Research Institute, that one I mentioned. Eric?
Hopefully he'll let us know here. Just a reminder, we'll put all the resources that Kris has referenced. We will also make sure that those get listed with the post-event
Yeah.
resources that we put on.
And so the top one here, references is really that seminal paper I talked about, pretty recent, so July of 2021. Really, it was written by who I consider national ROSC experts. And it gives you a really nice perspective on why this started, kind of those similarities I discussed between different civil rights groups, social justice groups, different movements, and how this work bubbles up in response to these grassroots efforts, and then gives us a snapshot of what's happened nationally and maybe where can we go with this in the future. And then the second reference here is from the Measuring the Impact of ROSC in Hancock County. So it's not only just a preview of the work they've done, but they have some data to show these outcomes and how transformational this process can be. And then the last one is a link to some efforts in Michigan.
Brooke commented that she loved the Healing Forest and learning about that. It was the first time hearing about Community Recovery Capital.
Yeah, that's exciting, Brooke. That's an area that interests me, and there's conversations kind of happening all over the place. We measure recovery capital, so a bunch of brilliant people create a assessment of recovery capital. And so it's again, it's a form that people can kind of fill out. So when somebody walks into a recovery community setting, it's looking at kind of the quality of life and different supports they have. It's not a clinical measure. And then you pick out periodically, you reassess that recovery capital so you can demonstrate growth over time, because we're having challenges with, we all know we all work within systems and we need data to support the work we do. We can't just always go on qualitative data and storytelling. Those are wonderful and good ways to collect data, but sometimes we need that concrete data that the investments the state or federal governments are making in our organizations are valuable, and that that we're seeing improvements in the quality of the life for the people we serve. Yeah, it's Dr. David Best. Even if you just Google his name, you'll get to his website. I can't remember the name, but you'll learn a ton around kind of the beginnings of recovery capital, where it's being measured, how it's being measured. I think he's from Leeds, and so he does a lot of work in Europe, and so they have like recovery friendly cities. So they come into a city and they do this work around recovery friendly cities. And so again, just a kind of a different approach to all this that we're talking about, and it's really fascinating work. And then the assessment I just referenced, there's a long version, and then now we have one called the BARC 10, so a brief assessment of recovery capital. And so it was reduced to 10 questions. Part of those efforts were because the initial assessment of recovery capital, I think it was around 75 questions. It was really long. And what we found out is it made a lot of times participants feel like, oh, this is just, you're another clinician. And like, I thought you were, a person with lived experience. And it kind of took it out of that feeling like I'm being helped in my community. And so, again, a very brilliant researcher took it down to 10 questions, and it's still a validated tool to measure somebody's recovery capital.
Excellent. Are there any other questions for Kris? You can unmute, you can type them in the chat.
I'll look for a couple of those links right now, Amanda, just so people can have them from the chat if they want.
Right. I'm going to move into closing out our session, giving our colleagues that much needed ending information. We've got some great comments for you, Kris. We also have a really nice reference to Dr. Ellswick's presentation on recovery capital in our first year. So you're welcome to go check that out. Thank you for popping the link in, Liz. All right, let's chat about how we wrap up today's session. Again, continue to pop your questions in. We can always come back to those after we end the recording here. But if you logged in from a link that was not through the registration, don't worry, you're not in trouble. We love that people share out these links. We want you to come and join, but we also want to make sure that you get the CEUs, the contact hours, because we don't do CEUs. We want you to make sure you do the contact hours so we can get the certificate out to you. So please send us to our Great Lakes ROTA email your full name and your email address so that we can get you out your contact hours, your little certificate for that, and make sure that you get added to our distribution list so that you know when other events are coming up in the future. That's super important because we've got a lot going on. If you weren't on earlier this month, then you won't know everything that's happening in February. We have this amazing youth mental health and social success series coming up in February that we'll be working on or talking about neurodiverse youth. Some great events in that series. We have more from the Know Your Resources series, so you really don't want to miss out. So please make sure that you get added to our distribution. The next thing I want to talk about in our next slide is our survey. I want to make sure they have a couple of different ways to get a hold of us here. I'm going to just pop in our email, our website, and a link for technical assistance. The next thing that we need to make sure you can do is fill out the evaluation. And I know that evaluations get a bit boring sometimes, but if you can at least fill out the first 5 questions on the survey, there's the link. That really helps us out. It helps our presenters out, helps us know what you find useful in our professional development series, what you're looking for as far as what we do in the future. So if you can just take a few minutes and fill out those first 5 at least, that helps us out a lot. We know that the GIPR data, the demographic data gets a little tedious, but it also helps us understand where we're making a reach, where we need to try and continue to make a better reach across our region. So thanks a lot for doing that each and every time that you check in. The last thing that we want to let you know is what are the next couple events that are coming up in the nearest of futures. The first one is psychoactive substances research. Let me get you the most up-to-date title on that because I know Dr. Brown just revised that. Is actually research on psychedelic compounds in the treatment of substance use disorders. It will be Monday, February 5th, 11 Central, 12 Eastern. Please check in. Dr. Randy Brown is the presenter on that event. He is part of our technical assistance grant here at ROTA. That will be an exciting presentation. He's a great speaker. He does a lot here at UW-Madison campus. And then our second event coming up is the very first in our Youth Mental Health and Social Success series. We will be having a showing of the Jordan Zimmerman This Is Not About Me video that will be 1 hour. Following that, there will be a presentation by an autism support specialist at one of our local middle and high schools. We'll be doing a presentation about the video and about how the implementation of authentic engagement and advocacy helps youth to be more involved in their care. So promises to be a couple of really great presentations. We hope that you can join us. That's it for us here today at ROTA. Thank you for joining us. It's always a pleasure to see all of you. I'm going to pause the recording now or stop the recording.